of the oration of the MOGS Dr. Dosibai J.R. Dadasaheb Silver Jubilee Oration. I am extremely humbled to welcome our chairpersons. Our chairperson, Dr. Vandana Valvikar ma'am. I welcome you, ma'am. Ma'am is in the board of trustees of MOGS and also was the past president MOGS. Dr. Bipin Pandit sir. Sir has been the past president of MOGS. And Dr. Shailesh Kore sir. Sir, I welcome you. Sir is the secretary MOGS. We welcome you, sir.
It gives me a great pleasure to invite today's orator, Dr. C.N. Purandare, sir, to please come on the dais. And again, a great pleasure to introduce about this oration, Dr. Dosibai J.R. Dadabai Silver Jubilee Oration. The prestigious Dr. Dosibai Silver Jubilee Oration was first ever instituted in the Bombay Obstetric Gynec Society, which is now Mumbai Obstetric Gynec Society now. Even in the life and times of Dr. Dadabai, the need to start an oration was deeply felt by one and all. The objective was to invite distinguished experts from India and abroad to share their erudition so that the members of the society may benefit from the same. Just after Dr. Dadabai's demise in 1960, an oration was instituted in her name. The last 5 orators were Dr. Asma Khalil from UK, Dr. Alpesh Gandhi from Ahmedabad, Dr. Jean Conray from USA, and Dr. Farooq Udwadia from Mumbai. So we welcome Dr. C.N. Purandare to give the oration.
Thank you, Vipin. It's a pleasure and a privilege to be introducing Ranjan Purandare, who's a dear friend and a colleague. And we've been friends for many, many years to both the families. So it has been a pleasure. Ranjan has been an iconic gynecologist, as all of us know. Not only in Foxy, but also in FIGO, one of the 3 OBGYN members of Indian society who have been representatives and presidents of FIGO, which is very, very commendable. He has had a very extensive career. He goes around all over the place and gives lectures. He has been an honorary member for 13 bloody countries. But he's a pleasure. He's an excellent surgeon. And he is very, very friendly, very, how do you say, very supportive of what people are doing. And to be, give you in on a listening, then we'll see, chorionic villus biopsy came into the profession. And when we were doing it, Ranjan had just come back from Ireland. And I think he showed me how to do it on his ultrasound machine. And that's how we got into these other investigations and procedures. So it's a pleasure and a privilege to introduce Dr. Ranjan Purandare for this oration. Dr. Purandare, please.
Thank you very much, Vandana, Bipin, and Shailesh. General introduction. And to talk about the oration that I am giving today, the Dadabai Dosibai oration, the lady concerned was a very close associate and friend of my grandfather, Dr. N.A. Purandare, who was one of the first qualified OBGY persons in the country. And at the same time, she went abroad and did her FRCS in 1903. And in 1925, when KEM Hospital was formed, Jivraj Mehta, who was that time the head of the KEM Hospital, invited Dr. N.A. Purandare to be the head of the Department of OBGY at KEM Hospital in 1925. And he requested that time, and Dadabai Dosabai joined in 1229 as one of the first woman OBGY consultants in KEM Hospital. There's a long legacy that I remember as 5-year-old. Dadabai Dosabai in a white sari would come to Chapati, and she was very fond of my father, and she would make him sit in her car and go to Marine Drive to chat for half an hour, 1 hour, and she was already that time maybe 70, 80 years old. And so it has been a long association, and it's good to give oration in her name today. And I'm going to talk today on something which is new, which is going to happen very soon. It has already been on the horizon as happening. But it will be available in India sometime about a year from now. And in September, October, it will be launched in Europe as alternative to forceps and one-tooth delivery. How does this move forward, folks? Hello, the slide is not moving. ये कह रहे हालत में अरे suddenly started going. Okay. Originally, which in 2012 was initially suggested as Odon device, has now been christened as Odon Assist, the new tool on the block, and a new option for assisted vaginal delivery. In 2012, when I was elected as president of FIGO, this particular device was put forward, and we saw it as a new thing which was coming in, and FIGO was requested to analyze the device to see whether it has any potential. Now, this device originally was designed by a mechanic, auto mechanic from Argentina. He had gone there for his wife's delivery, and he saw all sorts of struggles happening there, trying to deliver her with instruments and so on. And he said, why can't we devise something which is simpler? And he used to use a technique to take out the rubber, the cork from the wine bottle, to take it out of the bottle even when it has gone in. And the same technique, he said, why can't I use it to get the baby's head out from a space? Maybe it is, the opening is smaller than the head, which is bigger. The cork is also bigger than the bottle, and yet I am able to take it out. And he designed an instrument which was put to us through BD, the BD syringes, they had taken it over. And that device was about that long. And I was there on the committee as the FIGO president-elect, and then as the FIGO president in 2015. When at BD, I said, if you were to go with this big instrument in front of the patient to say that I'm going to deliver the baby out of with this instrument, they will run away. So we reduced the size, and we brought the size to about that size and modified the thing. And as I go along, I will explain to you how things have happened. Now, we all know that there's a rising trend in cesarean section rates in the changing world. Lot has been said, lot has been discussed that the section rates are rising. They are rising, and it means nobody can deny that. And if you look at the cesarean section rates, way back in 2012, China was always higher, because of the one-child norm, and they didn't want to do any normal deliveries. They did cesarean sections. But most of the other places you saw, Egypt 10.3, France 18, United States 29, and so on and so forth. But as time passed, the cesarean section rate started rising, and Brazil had 80% in private clinics. The cesarean section in Egypt, which was only 10.3%, today is standing at 55%. Enormous rise in the section rate. Causes may be multiple, some explainable, some which cannot be explained. And the cesarean section rate has nothing to do with evidence-based medicine. Why it is increasing, there is no evidence to suggest that it should increase and to the level that it is increasing. People complain that does it have more to do with the doctor's income as perceived by society, that section rate is higher because they are making more money. The doctor who does not want to work at night, or the doctor who has lost his or her skill to attend a difficult vaginal delivery. And interestingly, I remember way back about 20 years ago, maybe a little earlier also, Dr. Vandana Valvekar will probably remember that there was a paper which was published from Wadia Hospital to show that the cesarean section rate is higher in the evening than in the night because people wanted to finish their sections before starting consulting rooms. So the last is, of course, the medical legal issues that everybody knows that one has to face. When we talk about dystocia, this is the biggest issue in obstetrics. Everything can be blamed to dystocia. Say that, well, this is why the section has been run, and dystocia is very difficult to quantify, to say that this is particularly responsible for it. The progress in obstetrics, when you look at, is more difficult to achieve than many of us believe and think, that we can achieve much better the progress as far as obstetrics is concerned. But many doctors have lost their skills to attend a vaginal breech or twin delivery. Nobody wants to deliver a vaginal breech now. Many of the obstetricians even don't know how to deliver a breech vaginally. But sometimes I feel like telling them that if you are to do a section for a breech delivery, you're doing exactly the same technique as what you would do vaginally. Don't do anything different. And so also as far as twin delivery is concerned. But the most important thing that needs to bother us, need to look into, is the second stage of labor. Because that is when the instrumentation or whatever technique that you need to do to change that takes place. Now, second stage describes the event that takes place between full dilatation of the cervix in the time of delivery up to the birth of the singleton baby or the last baby in a multiple pregnancy. If you look at from the start of the second stage, the fetal presenting part may or may not be fully engaged, and meaning that the widest diameter has passed through the pelvic brim. The women may or may not have the urge to push, and that is why the progress may not happen. 4 months back, I was at an international conference when somebody presented a paper saying that there is no need to do vaginal examination. There is no need to assess the patient from below to see whether it is descending, not descending. Put in a transvaginal probe to see what is happening, and then you decide whether you want to deliver vaginally or you want to deliver by cesarean section. Why do you need a doctor in the first place there? Because the situation will arise now that there are only two types of doctors. One who does cesarean section, and the other one who doesn't go on time and the patient accidentally delivers vaginally. So she's already delivered and you land up there and, well, it's done anyway, so why worry about it? So the women may or may not have the urge to push, which is a very important thing, especially with the epidural analgesia that is being asked for by most of the patients today. Now, evaluation of second stage needs assessment of descent and duration of labor. And the partogram is supposed to be the golden standard to understand what the descent, how it is taking place, and the duration of labor that is taking place. And if you look at the relationship between the bony pelvis and the presenting part, you see the centimeters of the head going down to ischial spines. And all of us, at least my generation or maybe a little less, afterwards, after my generation to whom I trained, we all evaluated by doing a vaginal examination, where the spine is, where the baby's head is, where is the presenting part is, whether a bilateral diameter has come down, whatever it is, we checked by doing a proper vaginal examination. Now, when the art of doing that is slowly getting lost, when you start doing cesarean sections, the question is, how will you assess this situation as regards the descent of the baby's head? In 1917, I was in Shanghai for the Birth Congress. And China had that time changed their norm from one delivery to 2 babies norm. So we had about delegates there, about sitting 2,500 to 3,000 delegates. And would you believe that Chinese are very quick to learn? They had all my slides within 1 hour translated into Chinese. So while I was showing one slide, my slides which were English, there were Chinese slides coming up there within 1 hour. And they were able to relate to what was I saying because they didn't have a word of English. So there was somebody who was translating, and I said to them that I would like to know if any one of you or who amongst you have delivered a second baby, because the section rate is so high, 70–80%, who has delivered a second baby? Hardly anybody. I'm not talking about you, I'm talking about the Chinese. Now, the previous LSCS never have been delivered by them, so the question of rupture uterus was never heard of by them. It was somewhere in the books that they said there is something like rupture uterus. So then we come to a point that if you have to deliver somebody who is a previous LSCS, either you do 100% cesarean sections or attempt something which you have never heard of. If that is the situation which is existing, it is being transferred all over the world to say that previous LSCS, VBAC is out. You're talking about a repeat cesarean section. So the protracted descent that you're talking about when your instrumentation has to be evolved into, whether it's nulliparous when you say it's less than 1 centimeter per hour and multiparous which is 2 centimeter per hour, you know that the progress is happening. When it stops, then it starts again. So there are different levels of the protracted descent that will take place. The arrest of descent where it will stop, it will not progress further, and you need to give some augmentation to make sure that the progress will progress. And when the arrest of descent occurs, we're talking about dystocia back to square one to say people are confused that everything to be called a dystocia or actually what is happening. So the option is to do a cesarean section or operative vaginal delivery, which will be either vacuum or forceps. Now in my life from taking up obstetrics till today, I have seen so many changes happening regarding the decision to deliver vaginally vis-a-vis vacuum forceps and so on. In 1993 or somewhere around that, the RCOG said that you should be using ventouse and not forceps except for outlet deliveries, as this is dangerous to the baby. In 2000 and around 2000 to 2001, the approach softened a bit to say that when feasible, forceps delivery can be done, but vacuum also can be done. And 2008, they came up with that forceps should be preferred over one-tooth delivery because of the complications of one-tooth are more than the forceps delivery. Now, from 1992 to 2008, good 15 years, all the doctors who were trained under never did a forceps delivery. And in 2008, RCOG tells them, do forceps delivery. How will you do it? They have not done a forceps delivery before, and 15 years have gone back. So either you go back to the basics, to the mannequin to learn how to do a forceps delivery, or you can't do it. There are situations where I have done mid-cavity forceps for so many patients successfully, without any problem at all, because then you're trained to do that. If you're not trained to do that, you can't do it. How long are you going to allow second stage of labor? The duration of second stage of labor is a big issue because the moment cervix is dilated fully, you start asking the patient to push and she can't push and said, bang, in the next 10 minutes, 15 minutes, we are taking her up for cesarean because it's not progressed further. But it's been documented that increase in infant mortality when second stage is exceeded 150 minutes, which means that for a good hour and a half, you can wait, nothing will happen to the baby. If you monitor the baby properly to see that the fetal heart is well going properly, the head will eventually come down and you should be able to do her delivery vaginally. If the progress is being made, the duration of the second stage alone does not mandate intervention by operative delivery. And especially when epidural, when second stage of labor is bound to be delayed, first stage is accelerated and second stage is delayed. And that's a factual, evidence-based medicine that you must understand when you are attempting any delivery. Now, childbirth and pelvic floor injury. What is the price of a prolonged second stage on perinatal health and disease? You can't endlessly sit on it to say that, well, his heartbeat is fine, let it go on, maybe 2 hours, 3 hours, or whatever. The reason is this is what happens. Because if the diameter, the biparietal diameter is larger, if the baby is say 4.2 kilos or whatever, and you want to deliver her vaginally, obviously trauma is going to happen. And that needs to be avoided because you must understand that vaginal delivery at any cost is not the solution. You don't want to get the baby dead or alive, but vaginally has no meaning. You must look at the fetal well-being as well. So the labor, the first, shortest, and the most dangerous journey of a human being, which one takes right from the beginning when you're talking about vaginal delivery. And the second stage arrest when it takes place, you have a C-section, forceps, vacuum, and now the new device which is coming, the Odon device. Now it is important to accept that both instrumentally assisted deliveries and cesarean sections play an important and complementary role in modern obstetric practice. It's not one way or the other, that you have to have cesareans or you have to have a normal delivery, and patients may demand that it should be only normal delivery, but there should be a rider that the obstetrician decides that when a situation arises, the cesarean section is necessary, it should be done. Then the question is that when you're talking about instrumental deliveries vis-a-vis a cesarean section, today you see patients who say, I don't want forceps, I don't want episiotomy, I don't want this, I don't want that, I don't want cesarean also. But something is going to need. Whether it is vaginally, you may need instrumental delivery. And if you want a cesarean section, there are people who say, I only want cesarean, no, nothing else. So if that situation arises, we will have only two types of deliveries, either cesarean or accidental vaginal deliveries, which means that you do cesarean on your own. When the obstetrician is available, it is cesarean. If by chance he or she arrives late, then it is accidental vaginal delivery, because before that person arrives, the delivery has happened. So then that's okay, it's done. So it's a vaginal delivery that has happened. Now, the more things change, the more they remain the same. Think that you have changed something and it goes back to the basics. Say that it remains the same, that what you want to do go ahead. So in a clinical situation, the obstetrician is faced with the question, is instrument delivery feasible? Is instrumental delivery the best option to whatever you are doing? Which instrument would be most suited to the situation? Whether you are doing one-tooth, your forceps, or whatever, which instrument would be the best for this particular situation that exists? A valid option when problems arise during second stage of labor or alternative for C-section when the situation is so-called failure to progress in the lower pelvic straight is a forceps. And that has been documented that this is, if you know how to do it, it's a very important instrument as far as obstetrics is concerned. Forceps should be considered as an alternative for C-section when the situation so-called failure to progress in the lower pelvic straight occurs. And even though C-section is safer than it was 30 to 40 years ago, an abdominal delivery still carries the risk of maternal mortality several times that of a vaginal delivery. And this fact is often forgotten today in favor of fetal health and survival. ACOG in 2000 said that the mid-cavity forceps operation with rotation of 45 degrees or less, classified by the scheme proposed by the ACOG, are safe for mother and fetus, which also avoids unnecessary C-section and its complications. This is where the problem started. People didn't know how to do a forceps. And then you tell them, go back and do this rotation up to 45 degrees and then deliver it. But the basic fundamental thing that there are a lot of juniors here understand that there are three forces acting when you are doing forceps delivery. You have a compression force, which is constant because you have the forceps applied on the side of the baby's head. A traction force when you are pulling, which is always there. And if you are turning the head, there is rotational force. So there are three different forces that are acting as far as forceps is concerned. But a golden rule is that only two forces should act at a given time, not three. Which means if you are rotating, don't pull. If you are pulling, don't rotate, because the compression force remains constant. The forceps is already applied on the baby's head. So that's the cardinal rule for forceps deliveries, and abandon the operation if it doesn't not proceed smoothly. If you find that it's getting difficult, forget it. And there's no point in proving that I did something and got the baby out when all sorts of problems can subsequently happen. It is difficult to cause injury if one takes out the force out of the forceps. If you too much of force, that is where the problem is going to happen. Evaluate the reasons for difficulty and then allow further progress of labor or moving on to an abdominal delivery, period. That you are not able to do it vaginally, you need to do an abdominal one. Now, I've already shown you this slide that it's important to do 45-degree rotation possible, which means that you apply the forceps, rotate it first by 45 degrees, make it occipito anterior or occipito posterior, whatever you want to do, because that is the suture line vertical, and then take the babies out. A lot of the time when there is so much time lag between that and happening on the full dilatation that has taken place, there is caput and you can't figure out where the suture line is. There again the principle is that use your index finger. That index finger by the side of the head, go and palpate the ear and flip it, and you will know exactly where the head is. And once you know that the forceps has to go oblique like this or like this, whichever, the fenestra must go over the ear. And once that happens, you rotate it, whether it is occipito-anterior, occipito-posterior, whatever, rotation complete, then during contraction, you pull. So forceps use is faster, it is more successful in achieving delivery than Ventouse at higher sex stations, and this may be of immense importance in acute fetal jeopardy. Forceps are also more useful in occipito-posterior positions, and forceps is preferred by ACOG and RCOG guidelines of 2008. Coming back to the fundamentals, if you have lost the art of doing a forceps delivery, how do you ask somebody today, now from tomorrow, you start doing forceps and nothing else? So every great advance in science has issued from a new audacity of imagination. And that imagination only brings about to things which are completely different from what you are expecting. And here I'm going to present today a new device called as the Odon Assist. Now, I have already told you how it started off. We changed it into this in 2014, which you see the rubber, which was the children's game where you bow and arrow and whatever, and those flaps, and a bag which was used for creating the instrument to pull on the baby's head. It is modified in a long way because the rim which was there on the outer skirts of the outer part of the end of the device, the plastic bag, creating a vacuum by having a separate bag, etc., that was a little cumbersome. So a device which was then prepared, modified, was this particular device. I will show it to you while the video is being shown. This is how it initially functioned. That you put that central portion which is there, which is this cup, which you put on the baby's head. Just put the whole thing inside and put the cup on the baby's head. And having put that cup in, there are these flanges on the side. You can see these 4 flaps like that. These 4 flaps will go on the side of the baby's head, and then you push the bag, this plastic bag, over those 4 flanges up to the baby's neck. Just keep on pushing it and it will go up. I will show you the video later on, but it is a very, very simple thing. Now the fully assembled one, it has little bit changes which have been made. For inflating the sleeve is a bulb which is attached here. Very simple. So once you put that in, just pump in and the air will put a sleeve around the baby's head. So the main 2 components actually are the inside one, which is eventually going to come out, and the outside one, which is the bag. So the first innovative in operative vaginal delivery since forceps centuries and vacuum extractor, which has been for such a long time, this is a new thing which is now coming in the market. This will happen sometime in August, September, October in Europe, and sometime next year, maybe March, April, we will have it available as a sterile device getting into you for, instead of forceps or vacuum, to use this. It's a low cost, less traumatic, applied by mid-level providers, which means that you don't need a hi-fi obstetrician to do that. Even the nurse can put this in if she's sure that the baby just requires the pulling, and do that. Safety, feasibility, and preliminary efficacy has been studied. The efficacy of multi-country randomized trial has been done, including in WHO guidelines, management of labor and delivery, task shifting, humanitarian emergencies, RH and kits, especially in Africa and other countries where you may not have adequate staffing for deliveries to take place, and including in strategic developments by foundations and agencies. Now, why is it needed? To prevent maternal and newborn complications of second stage of labor, trauma while doing it, whether it is forceps or vacuum or whatever, hemorrhage because you are trying to manipulate with instruments, tears in the vagina and so on, infection because you are having too many instrumentations happening, birth asphyxia, maternal and newborn complications, and complications of second stage of labor itself. Now, assisted vaginal birth in the 21st century, prolonged or complicated second stage of labor requiring an assisted vaginal birth or emergency C-section, approximately 10 to 15% of the births. So you are using about 15-20% instrumental, then the cesarean section, whatever, becoming 70-80%. The WHO said that beyond 15%, there is no advantage in increasing the cesarean section rate. But that was some time back, and there is no such thing as percentages which you can put down as a figure for cesarean. A woman who needs cesarean section needs it. That's full stop. This business of politicians saying that your section rate is going on up to 20%, 22%, but what are the type of patients that are dealing today vis-a-vis that happened 30 years ago? You had a 20-year-old patient coming in for delivery who delivered normally, perineum nicely distending, etc. And we have now 35, 40-year-old primary gravida, IVF patient, etc., high-risk pregnancy, and in all that you expect vaginal delivery and complications, and if something goes wrong, you had it. We have a medico-legal expert here who will be standing against you there to say that you have been stupid enough to do attempt a vaginal delivery in such situations. So now let us go on to the inflatable device for assisted vaginal delivery. It is an innovative one designed to enable obstetricians to assist vaginal birth. Mechanism is based on the soft air cushion placed over the fetal head, and in all clinical trials, Odon Assist was demonstrated to be safe for the baby with no typical pattern of neonatal bruising or injury, and the efficacy successfully assisted birth rate with Odon Assist clinical trials was 88%. That's a huge, huge difference when you're talking about instrumental delivery vis-a-vis a cesarean section that is did. How does it work? Now I am going to show you video. This is the instrument, and there you see that cup, white cup, which is going onto the baby's head. Then the bag, the white 4 prongs which are going by the side of the baby's head, and the entire bag is going over the aids to the, and then you take the middle portion out. The air cushion which is there, which is under the chin, you start pulling on your shopping bag, and the shopping bag gets the baby out, the head is out, you take the bag out by releasing the pressure from, there is a just knob which you turn and the pressure goes down, and that's the baby's head which is out, and you deliver the baby. It's so simple as that. There is no compression force. Traction force is below the jaw, so it is not happening at the time on the head per se, and there are no other problems there. The the product development, bench test, stimulation studies have all gone through from around 2017 to 2020. UK, extensive trials have been done. Registration CE mark is expected to be available by September. And the post-market trial plans are already on with the clinical introduction of in Italy, UK, France, and Belgium. Numerous papers have been published, and the clinical study evidence and data shows that 3 clinical trials completed in UK, France, 248 women experienced prolonged or complicated labor sponsored by UK NHS and Besseganon University Hospital, funded by the Bill and Melinda Gates Foundation. Trials have been done to show that clinical study evidence of data, summary of results, that there is no device-related serious maternal adverse reaction. The comfort is that well accepted and very popular among mothers, irrespective of whether they were administered epidural analgesia or not, because you are able to palpate the abdomen. When the contraction is coming up, just pull on it. She doesn't have to push it out. And no device-related serious neonatal adverse reactions have been seen, and successful delivery rate was as high as 88.5%. Related by obstetrician as use, rated by obstetrician, same application technique was used for all fetal cephalic vertex positions. Medium time for application to birth was 5 to 8 minutes. From the time we apply to the baby delivered, 5 to 8 minutes, the baby is delivered. So we have a new tool coming in, which is the way forward. Odon Assist is a new and effective option that is very popular with women and obstetricians, has important potential benefits for babies. Safety and efficacy studied in UK and France and have been completed. Others are planned in several European countries as part of the program for clinical introduction in Europe. Not available on the market yet, but MNHI are excited to potentially work with Foxy. Madhuri. The Odon Assist is very happy to work with Foxy to prepare for implementation in India, including possible clinical trials. Any of those hospitals which are really willing to do clinical trial, we can do those clinical trials there, maybe 200 in major hospitals. So getting numbers is not an issue in this country. So you can have 1,000 number in no time. And that along with FIGO can be taken up as a way forward. Now, imagination is more important than knowledge, says Einstein, but Henry Ford, when he was asked about the car, about the horsepower, if I'd asked my customers what they wanted, they would have said, give me a faster horse. You try to come from airport to here, you will probably reach on the horse faster than taking your Uber down into St. Regis Hotel. So in 2012, before Margaret Chan handed over to Ted Ross, she said that the Odon device developed by WHO and now undergoing clinical trials offers a low-cost, simplified way to deliver babies and protect mothers when labor is prolonged. It promises to transfer life-saving capacity to rural health posts, which almost never have the facilities and staff to perform a cesarean section. If approved, the Odon device will be the first simple new tool for assisted delivery since forceps and vacuum extractors were introduced centuries ago. Numerous different varieties of forceps and numerous various methods which have been used. So in FIGO, the Maternal Health Committee put up this, that may all midwives and physicians be prepared. The proper teaching of obstetrics ought to be geared towards adding skills and not limiting them. You add your skills into various type of deliveries that you're doing and not say that cesarean section is the only answer and nothing else to be done. I cannot persuade myself that women or their babies are truly well served when physicians are no longer taught the skill to safely assist all of those babies who can be vaginally born. And I ask you to join that chorus to say that let us deliver them vaginally rather than only by cesarean section. Thank you very much.
Thank you, Dr. Ranjan, for a lovely lecture and a lovely demonstration. I have a feeling that this particular device can be used when the cervical rim also is present as compared to forceps, and that might be an advantage in deliveries, a significant, from what I have seen on the screen. So it's something new, something interesting, and something conservative, which is very, very important. And let's hope we have more hold-on deliveries.
I would slightly beg to differ that when there is cervix still there, pushing that bag over onto the baby's neck may not be as simple or easy as you think. Because it has to go over all the area entirely. It can't be like forceps. If you are doing it with a rim, yes, or one-twos, yes, because you are not going right up to the baby's neck. Here you are only up to the ear or you are only to the scalp. While if you're doing Odon, you have to go right down to the baby's neck. And if the cervix rim is still there, it may not be able to push it beyond. So we are talking about a situation where cervix is fully dilated, second stage of labor, and then we go ahead managing the deliveries with this. Thank you very much.
It is
हे झालेलं आहे.
It is my proud privilege to have Sir here as the orator. As the first orator of my year, Madam, Sir, I'm very, 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 very humbled, and I'm thankful to whatever you have done for MOGS, whatever you have done for Foxy, and whatever you have done for Figo. So don't you think, friends, he deserves a standing ovation? We are really, really very, very lucky to be your students, sir. And we are really lucky to have you amongst us today. And please continue your support forever. Thank you so much, sir. I have the pleasure of reading the plaque, the Mumbai Obstetric Gynecological Society, MOGS, Dr. Doshibai Dadabai Silver Jubilee Oration is conferred upon orator Dr. C.N. Purandare on instrumental vaginal deliveries, Odon device. You may be seated, all of you can be comfortable. Yeah. Odon device. On 6th April 2024, MOGS Presidential Installation Conference at St. Regis Hospital on obstetric challenges and dilemmas, signed by Dr. Suvarna Khadilkar, that's myself, President MOGS, to be Dr. Geeta Balsarkar, Secretary MOGS to be, and Dr. Sujata Dalvi, Treasurer MOGS to be. So Geeta, are you there? Geeta, please come. Is Sujata there?